Really a pleasure to be.
Sorry,
It's really, oh,
that was me.
sorry. It's really a pleasure to be with you all today, and thank you for the invitation. Samantha and I have been. I'm acquainted with Alan for a few months now, and it's really incredible to see the work that you're doing, and basically the. I've come to appreciate the importance of patient advocacy groups in diseases, and it really plays a big role. So thank you, everyone. So today, next slide, please. Yeah. So yeah, I'll no real relevant conflicts to my talk today. I do receive funding from BMS for conducting clinical trials at my institution. And now I'm a hematologist, so I treat patients with blood disorders, primarily acute leukemia, but also other sort of leukemias like myelodysplastic syndromes and chronic leukemias and such. And I also am involved with allogeneic bone marrow transplant for those patients. Next slide, please. All right, so the objectives of today's talk is I'll review the latest outcomes for acute leukemias and how we have come in the last few decades, primarily focusing on acute myeloid leukemia and acute lymphoblastic leukemia. And then I'll review why this change in outcomes has come about, and sort of review the contemporary treatment landscape, and then present some opportunities for the future. Next slide, please. So this is basically a sort of an overview of how the leukemia outcomes have evolved. And thankfully, if you see the top line, the pink line here, the outcomes are sort of slowly improving. The primary improvement is in patients under the age of 60 years. However, we are seeing some improvement now in the age greater than 60 years of group as well. Now, if you look at these curves, we have come a long way from, previous slide, please. Yeah, so if you look at the 1970s, only 20% of 10 to 20% of patients used to make it to 10 years. Now that number has increased to almost to a little bit over 50%, which in itself is an improvement. But it's not ideal. We obviously want these curves right up there, and we want 90-100% patients making it to long-term survival. And this is hopefully going to happen in the next few decades. But let's first look at how we have gotten this far. Next slide, please. If you look at acute leukemia, it's a very unique illness, and in a way, the quality of life for acute leukemia is tied to the treatment. And what do I mean by that? So just to give you an example, if I have a patient with cancer, let's say some other malignancy like breast cancer or lung cancer, oftentimes the treatments are, it's either you get the intensive treatment or you go on a sort of a palliative care route. And in acute leukemia, the quality of life is tied inherently to the disease itself. If you have active disease, your quality of life is going to be very, very bad. So paradoxically, a lot of the times, even the more sicker and older patients end up deriving benefit from intensive treatment. And you can see this in this chart here, where even in ECOG performance status 3 or 4, which is basically patients who are not able to do their daily activities, who are bedbound, even such patients, when they get intensive treatment, they derive a benefit and their quality of life is actually better. Now, not all of them can handle it, and so it's a very individual decision for physicians to decide which patients to treat aggressively versus a palliative care approach. I have to tell you that physicians in the US and oncologists in the US have actually historically been a little bit sort of gun shy about trying intensive treatments for older AML patients. And now I think it's changing as more data comes about. And thankfully now we have better treatments in this regard. Next slide, please. So the improvement in outcomes for acute leukemia has largely been limited to certain subtypes. Acute promyelocytic leukemia, we are almost curing most of the patients, as you can see. Core binding factor leukemia, which is a specific type of leukemia, 821 and version 16, there now the outcomes are, again, sort of similar to APL. We're curing majority of these people. Next slide, please. However, I mean, this is the genetic landscape of acute leukemias, acute myeloid leukemias specifically. As you can see, it's not just one disease. There are many, many different diseases embedded in this sort of category. And really, we need to think about this disease as a distinct, so there are many different entities within it. And if we have to improve outcomes, we have to find sort of specific targeted therapies for each of these sort of genetic drivers. Next slide, please. And this again goes on to show that no matter what genetic drivers you have for acute leukemia, you have sort of different outcomes based on that. And on the top here, the top curves here are basically of the core binding factor leukemias, the inversion 16, 15, 17 is the APL. But if you look at the bottom curves here, the ones in red especially, now these are some really, really more aggressive leukemias where no matter what treatment we throw, it simply does not work. And I think that needs to be, this sort of is an area of need that we need to work better at sort of focusing on these subtypes. We have to improve outcomes even further than what has happened. Next slide, please. TP53 mutant acute leukemia is especially a very aggressive leukemia. I think majority of patients who are diagnosed with this particular subtype, TP53 and complex karyotype, unfortunately, almost all of them succumb to their illness, and none of the patients, in fact, in our experience, make it beyond 5 years. So this is, again, these are some of the subtypes. And similarly, there's another subtype called ASXL1 mutant AML, which is, again, a very unique sort of entity and has historically very poor outcomes. Next slide, please. So right now, this is our algorithm for acute myeloid leukemia. If you have patients eligible for intensive therapy, you have several options depending on what the genetic subtype is. So the core binding factor leukemia, CBF leukemias, are treated with intensive chemotherapy. Then you have FLT3. Now there are several FLT3 inhibitors that are now coming out and that are combined with the intensive chemotherapy. And newer drugs such as CPX351, these have been approved. CPX351 is basically a 7+3. The previous chemotherapy, we used to use the 7+3. It's just a repackaged version of that in a different sort of a formulation. And that's more sort of accessible and more sort of has more capacity for cancer killing. And so those are the standard approach. A couple of drugs that have come about that have really changed the last few years of treatment. And if I have to pick one, that would be venetoclax. Venetoclax is now changing treatment for pretty much all of the patients, and we are trying to incorporate venetoclax earlier in the treatment. And this is a pill, essentially, so it's not as intensive as some of the IV chemotherapy that we used to use, but it still requires hospital stay. It's still involved with a lot of sort of side effects, infections, weakness, and so on and so forth. So it's not a walk in the park, but it's still it's an effective drug nonetheless. So venetoclax has changed the landscape, and then there are newer targeted treatments that are now changing the landscape, such as IDH1 inhibitors. So now these are IDH1 and IDH2 are mutations seen in the cells, and we have now drugs against those as well. Gemtuzumab ozogamicin is now another targeted treatment that we're adding in certain types of AML. However, if patients are not eligible for intensive chemotherapy, then we are now stuck, and we have to sort of use either the targeted therapies or go on the palliative care sort of an approach. And then, as I said earlier, this the TP53 mutant AML unfortunately has no sort of effective treatments, in my opinion. We sort of encourage early enrollment in clinical trials, and if they achieve a remission, then see if they can get to an allogeneic bone marrow transplant. Next slide, please. So if you go from the 1960s to 2020, if you look at the box on the right, so many options now that are approved in the last sort of decade, versus the 1960s to 2000s, we barely had the 7 and 3, decitabine, azacitidine, and that's it. But now in the last decade, there have been at least 6 to 7 new therapies that have been approved, which is encouraging, exciting, but also that there's a long way to go. Next slide, please. Now let's come to acute lymphoblastic leukemia. So this is sort of a different type of leukemia. Acute myeloid leukemia is primarily, it starts with the white blood cells. That's the origin. The lymphoblastic leukemia, the origin is the lymphoblast, which is basically the source of the immune cells, the lymphocytes. And we sort of lump them together too, but essentially they're different diseases, and they're treated differently with different types of chemotherapy. And if you look at the data from 1980s to 2010, as you can see, the survival is improving, which is encouraging again. By decade, every decade, you have sort of an incremental improvement in survival.
Translation, or would that be responsibility of the organization?
Sorry, next slide, please. There you go. Now, if you go by the age, if you look at now acute lymphoblastic leukemia, unfortunately, the most common type of leukemia in young children, and it's heartbreaking to see young kids deal with this, but fortunately for the young infants and children, the survival is excellent. I think the survival is in the range of 85 to 90%, 5 years, and most of the young kids, if they're diagnosed with it, are cured of their illness. And the reasons are still unclear. I think there are some genetic differences in the type of leukemia that happens in young kids versus adults. And also the tolerability of treatment, certain drugs is a lot better in young kids. But if you look at the other sort of decades, 15 to 19, and this, incrementally the survival is poorer. Again, as with the AML, the age 60 plus, age 70 plus population tends to do poorly. Next slide, please. Again, this shows the same thing. I think the maximum increment that we have had in improvement in survival in ALL, again, in the last decade has been in sort of this younger ALL population, and that's sort of loosely defined as age less than 40 years of age. And as you can see here, the incremental advantage has been quite excellent in the younger adults. Next slide. If you compare it to the sort of the elderly population, the survival benefits now sort of wane away. 40 to 59 is great. 60 to 69 is a little bit better, but the 70 plus population again is something that we need to work on. And if you look at the median values here, they are quite shocking. I think if you're diagnosed with ALL, if you're older than 70, the median survival is only 4 months, and that's just the median. So there are some that do a lot worse. There are some that do a little bit better. But this just goes on to show that we still have a long way to go in terms of improving outcomes for these patients. Yeah. Next slide, please. Yeah. I'd like to highlight a specific type of acute lymphoblastic leukemia, and that's the Philadelphia chromosome positive lymphoblastic leukemia. This is often a subtype that is associated with poor outcomes, and regardless of whether a younger adult is diagnosed with this or an older individual, we tend to sort of take these patients and offer them an allogeneic stem cell transplant. And it's there are now some new drugs that can be used. For example, the tyrosine kinase inhibitors that were used in chronic myeloid leukemia can sort of be used in this population as well. But this is again another area that that needs to be worked on, and we need to sort of hopefully improve outcomes for this population as well. Next slide, please. Now, looking at the drugs for ALL, and ALL is loosely sort of divided into two broad categories, and there are several subcategories within them, but B lymphoblastic leukemia is a unique subtype, and this is the most common type of ALL, so the B ALL, and then you have the T ALL, which is the T lymphocytic leukemia. And majority of the improvements that we have seen in treatments have been in the B ALL category, and this includes drugs such as inotuzumab and blinatumomab. Now, these are sort of the inotuzumab is a antibody that's targeted to CD22, and then that antibody is then attached to a chemotherapy called killikimycin. So it's sort of a newer age targeted treatment where you basically give this infusion, and it's supposed to technically just go and attack the cancer cells that have the CD22 sort of signal on marker on them. And now this is a different approach than before, where we used to just use heavy duty sort of chemotherapy, where we were able to sort of just combine different sort of high dose chemotherapy and kill the cancer. But in doing so, we caused a lot of collateral damage, and we used to have a lot of toxicity. Not that inotuzumab does not have toxicity, it does have certain unique toxicities that we deal with, but in general, this is a much better tolerated drug than the heavy-duty chemotherapy we used to use. If you look at the response rates, now these are different studies that have been done in the US and Europe, and basically the response rates are in the range of 80% complete remission rates, which is quite impressive. And the median survival, again, is still something, it's not great, but it's a lot better than what it used to be. Anything in excess of 80% the CR rate is quite impressive. And then the MRD rate basically means very deep remission, measurable residual disease eradication. So that basically means how many patients, when we do the bone marrow at the end of the treatment, we're able to not detect leukemia at all using whatever technology we have. And those rates are also quite impressive in this population, so it's in the range of 80% in most studies. The next option that came about was that has changed treatment and that we use very commonly is blinatumomab. Now, this is a newer age immunotherapy where you have a targeted antibody treatment that attacks the CD3 and CD19. So basically, in a sense, what it does is it brings the cancer cells and your own body's immune cells together. And the immune cell is then supposed to sort of kill the cancer cell. So this is a newer age sort of a treatment. Again, it's being used successfully in ALL. Now the response rates here they may not seem as good as the inotuzumab, but remember, there's no chemotherapy attached to this one. This is all just immune system directed treatment. And also most of the studies used very heavily treated populations, so relapsed refractory, where patients had already received multiple lines of treatment. And then you have, basically you try this to see if that can work or not. But it is a very useful treatment, and something that is now, I think I would say we use routinely in patients. Next slide, please. And we have finally the CAR T cell therapy, which is now in the last 5 years has almost completely changed the landscape for a number of blood cancers, primarily multiple myeloma and diffuse large B-cell lymphomas, but also acute lymphoblastic leukemia. The CD19, basically CAR T cells are, for those of you not familiar, then basically it's just you extract blood cells from the patient, you isolate the T lymphocytes, the immune cells, and then you engineer them in the laboratory to sort of make them efficient cancer-killing machines, and then you infuse those cells back in the patient. So this is like a cutting-edge treatment. The caveat of CAR T-cell therapy is that you need to have a target, and acute lymphoblastic leukemia is a prime candidate for CAR T-cell therapy because it has a target. So it has the CD19 or CD22 often, and we can use this sort of treatment for that. Acute myeloid leukemia, unfortunately, we don't have great targets, and CAR T-cell therapy has not been as successful as of now, but obviously things are improving, and hopefully we will have CAR T-cell therapy in that population as well. But, so this is now being used more and more, and a lot of the times, and if you look at these response rates, they're quite impressive in the 80 to 90% range. And remember, these are patients that have been through 4 or 5 different types of treatments before already. So this is a heavily pretreated sort of population. Next slide, please. So now, just opportunities for improvement. So I just gave you an overview of what the treatment landscape is for both AML and ALL, but and survival has improved in the last decade or so, but it's still not enough. We would like to see certain subtypes that have poor outcomes improve as well. So some types of acute leukemia, like the TP53 subgroup, the ASXL1 subgroup, the Philadelphia chromosome positive ALL subgroup, these are some patients that still do poorly long-term, and the disease almost always comes back. So this is an area that we need to focus on. Quality of life is ignored, and we don't do a great job in addressing it, both as physicians and also as investigators, and as basically the medical team entirely. And the drug development is now sort of geared simply towards response rates and survival. And we don't have great drugs to combat sort of the quality of life issues that we encounter in patients. So I think the way to solve it is to sort of, try to do more studies, get validated, standardized cure quality of life endpoints. And I know that Alan has done some great work in this regard. And we need to sort of have more of these studies come about, and more of these sort of standardized endpoints, because then we can go to the regulatory agencies and say that, this is validated, used across the world. And we need to use these endpoints as well in trials to really then ascertain whether the drugs that we are using are truly helpful or not, and not just improving survival. And optimizing supportive care. Now, this is a very important aspect of care in acute leukemia. And by supportive care, I mean medicines that we use to provide to support the patient as they go through this treatment. Antibiotics are a big part of that. And a lot of the improvement in outcomes that I showed is not just because of the cancer drugs, it's also because of our antibiotics are improving, and we are preventing and treating infections more readily. And also drugs to improve nausea, vomiting, those kind of things, and makes the treatment more sort of palatable. And if we are able to do that by providing good supportive care, then it's likely that we'll be able to sort of continue treatment for a lot more patients for a longer duration. So that's important. And thinking beyond drugs, right now we are heavily focused on sort of just finding drugs that induce a remission. Some of the drugs that have been approved, unfortunately, have had only marginal benefit, and yet they have improved. So they've improved survival from, say, 6 months to 8 months, 2 months improvement, and yet they're approved. And some of it is, we have to think carefully about the cost and benefit, and this is where the QOL, quality of life, would really come into play, because if the drugs are maybe not improving survival as much, but they're making patients feel better during those 2 months, then I think that's the way to go. So we need to really involve counseling early in the care of patients. We need to involve patient advocacy groups like yours in sort of in the traditional medical system of care. And we need to be able to provide holistic care for patients, because acute leukemia, unfortunately, is a earth-shattering diagnosis. It's relatively old. Next slide, please. So I think this is my second last slide. So last few years, we have seen tremendous boost in new drug approvals. It's encouraging to be in this field now. Survival is improving, but there's still a lot of work that needs to be done. And we need to focus on drugs that induce not only remission, but also improve quality of life and tackle issues that are often ignored, like fatigue, loss of appetite, nausea, vomiting, long-term complications like osteoporosis and those kind of things. And think beyond drugs and improve sort of a more use sort of the ancillary support systems that we have, social, psychological, and financial counseling. And also patient advocacy groups to sort of make sure that we can ease the journey as much as possible for the patients as they get diagnosed with this illness. So that's all I have, I think. Thank you. Thank you for the opportunity. Happy to take any questions.
Thanks a lot. So I cannot see the screen because I'm screen sharing. So if anyone has any questions, just please unmute yourself and ask your question.
Well, maybe if nobody asks, and then I'll come up and ask question. Thank you for the presentation, and I want to relate to what you said about involving patient organization and the role of patient organization. Well, it so happened that I just had a call this morning from a child of an AML patient, and she actually wanted to hear what kind of hope we can give her mother. And in many other hemato-oncology diseases, we can offer a lot of hope, of course, in the chronic myeloid leukemia, in the CML, in CLL, also in lymphomas. But it's very difficult to do it in the acute leukemia arena, as you said, because there are no answers to many of the subtypes of with all the advancement, we still need a lot of improvement. And so what can we as patient organization really offer patients when they are coming to us looking for any hope or any future?
Yeah, that's a very important question. I think that's, it can be quite challenging to address those questions for acute lymphoblastic leukemia or acute myeloid leukemias, and the reason being, this is not a unique, just one disease. It's there are so many subtypes that are it's so genetically heterogeneous that the prognosis is very different for certain subtypes versus the others. I think that's it can be challenging. However, I have to say that I think no matter how much we prognosticate these illnesses and we say that, okay, this subtype is going to do poor, this subtype is going to do fine, we always have success stories for all sort of these, all of these subtypes. I think it's important to give patients hope. I think that's important. Sometimes we, as physicians and as oncologists and cancer doctors, we end up not doing that for the fear of, just providing them false hope or providing them some misinformation, or, but I think that I have seen, at least in my short career so far, several stories of where basically I've been surprised and there have been successful outcomes. I think that would be important for, organizations like yours to provide the patients, and provide the patients some stories, and with the disclaimer that it's not like you're going to have this outcome, but also there are like stories of hope. And most patients are sort of wise, and they realize that nobody can tell them how long they have to live or how long, but sometimes they just want to hear success stories. And maybe if you can collect some stories like that, and I can sort of off the top of my head think of many such examples where I have sort of sat with patients and told them that, I'm not sure that this is going to turn out well for you. And then here I am 5 years later with them, and they're doing well. So I think sharing stories like that would be something that you should look at, because in initial days that patients go through, they go through some tough times, and we deal with a lot of it's a life-changing event. There's a lot of depression. There's a lot of sort of negativity, and the way the hospital system works is everybody wants to give you accurate information, but nobody wants to sort of sit down with you and tell, talk about these things. So it'll be important for your group to do that and come up with something like that. Yeah.
Thanks. I think Jan, you have a question.
Yeah, I mean, thank you so much for a very interesting presentation. And what struck me in the presentation was that we were saying the clinical community actually does not much about quality of life. And I mean, while I understand from the first curves you have shown, which are still quite depressing because survival is still very bad despite all the research, still all the people that are under the curve still live on. So what's that kind of disconnect that everyone puts their effort on survival and on efficacy of drugs and so on, which is without doubt important, but it's still 1/3 of patients who need to live on and suffer severely from quality of life. So why is there this disconnect of lack of attention on quality of life in clinical then?
Yeah, that's an important question. I think what I said was, I think the focus of the drug development right now is on purely improving survival. And I think that's what I meant. I think depends on the medical system that you go to, really. I think most physicians, nurses, the teams do sort of try to do the best job they can to sort of focus on both aspects, not just survival, but also focus on, symptom management, quality of life, and so on. But right now, the sort of the approval and the focus of the drug development is primarily on improving survival and reducing remission, and that has to change. And I think there are obviously barriers to that, and one sort of primary barrier where I think we can do better is to have validated endpoints that the regulatory organizations can actually trust. I think that's the biggest barrier in improving or sort of getting the focus on quality of life in this space, because it's very easy for it's an objective data. If you use a remission as objective, you can look at the slides and you can look at the labs and say that, okay, you're in remission. But how can you for certain say that you're improving quality of life? Obviously, the investigators will say, yes, their drug improves quality of life, but is that really objective? Is that validated? And I think that is the biggest barrier, as I see. The more studies we do as sort of organizations, institutions, and come up with sort of validated scales, validated scores, and the more we incorporate these in trials, the better it will be for the regulatory agencies to actually trust those endpoints. Yeah, I think that's what I really meant when I said, I think we're sort of ignoring quality of life. Not so much like the doctors themselves are doing that. I think they do the best they can to sort of focus on both things and sort of focus on, not just improving survival, but also making sure that the symptoms and all are managed well. One area where we actively are now looking at is involving palliative care early in our leukemia care for patients. And we're doing studies in that where we have palliative care, our palliative care colleagues come in early, regardless of whether the patient's requested or not, so to sort of help initially and offer that intervention early. And that has sort of made a difference. So we want to do more of those initiatives going forward.
Sorry, there's one more question from Ananda, and then
yes,
we can
hi.
move on.
Thanks a lot for that presentation, which yeah, well, it gives hope, but you know, the data is still quite dreadful. And so I do understand. I mean, we've had other examples where quality of life wasn't as important, like with our colleagues in melanoma, focusing on the survival of their patient community, and then at some point quality of life increased in importance. People were surviving and they were struggling with the effects of the drugs, and the treatment, and yeah, and with late effects of that treatment, which is, you know, a luxury for that disease. And I guess and hope that that will happen at some point with acute leukemias as well. But my question now, because what I did understand is that there is an appetite from the clinical community to understand quality of life and to capture it and to increasingly focus on it. And so I would like to know from you what the patient community can do to help you understand that. What would help you and the clinical community to understand it better, to capture quality of life in an appropriate way, that it helps you do your work better?
That's a great question. I think that's it's very important, I think, to involve the patients. I think the way you can, I think, help is, first, let me just clarify, I think the differences between, you mentioned melanoma. I think the completely different illness, and as you alluded to, patients live longer, and oftentimes in solid tumors, which is the breast and lung and melanoma and such, you have a clear distinction. You either get intensive treatment, we can make your cancer better, or we can not do that and just focus on your quality of life. And there's a distinction like that. It's very difficult to make that distinction in AML, because patients feel bad because of, you know, their blood is, you know, they don't have blood essentially. Their counts are low, and if you don't treat them, their quality of life is going to be poor. So even if you offer intensive treatment to these patients, you're sort of improving their quality of life. And as I showed some graphs, even patients who couldn't take care of themselves, couldn't get out of bed, if they got intensive chemotherapy, their quality of life improved. So there's a distinction that needs to be made in these illnesses. Now, to answer your question, what can patients do? I think that there has to be more engagement with professional societies. Alan is a great example of how patients are partnering with with the community and sort of coming up with endpoints, and it's important for patients to sort of play a more critical role in engaging themselves with professional societies, be it ASCO, Clinical Oncology, American Society of Hematology, European societies, ESMO, and so on and so forth, and come up with initiatives that can sort of that can provide guidance on how do we design endpoints, and how do we design sort of these questionnaires, and whatever we can do to sort of come up with validated endpoints for assessing quality of life. And right now there are several metrics. I mean, there are several scores that you can use to use quality of life, or sort of to track quality of life. But it's very generic, right? I mean, you can't use just a single score and apply it to every single disease. You need to have sort of disease-specific scores. You need to have different scores for AML, ALL, maybe, and chronic illnesses. And if you go down that route, I think that would be great. And there are some efforts already being done by cooperative groups and professional societies. So patient engagement is very important. The other area where I think patients can help is partner with grant funding agencies and be part of review panels, and sort of focus and try to provide input on what sort of studies we want to fund. That can be challenging sometimes. There has to be sort of engagement on both ends, but that's one area where we can really help. And not just grant funding opportunities, but also sort of a lot of the clinical trials also get funded through different grants. And so make sure that you you can sort of engage with those societies and provide input from your end. I give you an example. I think ASCO now is already doing that. They're involving patient advocates and they're involving patients to sort of be part of review panels and really have their input into what sort of projects should we be funding, and not just the scientific part, but also the part that is more meaningful for patients. So those are some of the areas. Obviously, engage in utilize social media and engage in with the community that way. That's also very important, and it's changing quite a bit. I think Twitter and other social media platforms are great at connecting people, and that's exactly how I connected with Samantha. I mean, I wouldn't have been able to connect with her. So it's a great, you need to engage with that, and that creating awareness through social media platforms as to what is meaningful for patients would really sort of provide visibility for your concerns to the community. And sometimes especially the scientific community where most of the drugs are designed are in the research labs. And most of the people who design those drugs and develop those drugs are not physicians. They are sort of biologists. So they don't know what are the concerns sometimes. And their focus is simply on inducing remissions and killing the cancer cell, but they don't know the concerns often. Physician scientists are great because they have their foot in both doors. They also do the research, but they also are engaged in patients. But those are fewer in number. I think most of the drugs that are designed are in sort of research labs with biologists. So I think those are some of the things that you can help with. Yeah.
Thanks a lot. Okay, so if you can stay, Abhishek, that would be probably interesting for you to hear about our quality of life survey.
Sure.
I'm just going to take the freedom to go back if the slides move. Thank you. I just go back to this slide because I think it's a very nice transition to what Zach is going to talk about. So you have been saying quality of life is still an issue, and of course also there's more to do just beyond treating patients with drugs. So now, Zach, I don't know if you are online because I cannot see.
I'm here.
You are, yes. So
that's good. Thank you. It's funny, totally not rehearsed. I was going to say exactly the same thing, Samantha. I really liked the line around beyond drugs, providing social, psychological, and financial counselling and support during therapy. Really on the money. So a really interesting talk, Abhishek. Thank you very much. So for me, I'm going to talk about what Alan's been doing in quality of life. We've been working on a project really from the beginning of Alan as an organisation. And I'm excited after a long time to be able to share more of the findings. We've put some of it in the public domain already, but to put more of it in the public domain now. So next slide, please, Samantha. So the first thing is really, why did we want to do a quality of life survey as Alan? When we came together as an organisation in 2017, it was one of the first things we set out to do. It was pretty much our first project. And as Samantha said at the beginning, we are an evidence-based organisation. We believe in everything that we do from an advocacy perspective, making sure we follow the best practices in evidence-based advocacy and really having that strong evidence base for all of the work that we're following through. So it was important to do from that perspective, but it was also really important because of the issues that we were trying to track. So as Abhishek's really well highlighted, the prognosis in acute leukemia has been incredibly poor, and historically there's been a lot of narrative that quality of life doesn't matter in acute leukemia, which we strongly disagreed with. And particularly with all of the changes that are going on that we've already heard about, we wanted to reflect how acute leukemia quality of life was changing and what difference some of those new treatments might be making, and the fact that we should put increased prioritization on the topic of quality of life. Next slide, please. So it's been a long journey. Like I said, the actual project sort of kicked off in 2019, but it was in the planning all the way back from 2017. So it's taken us quite a while to get here with some of this. It's been a mammoth effort, but we're kind of coming towards the end of the project, and it's really nice to be able to share the outputs. We've got lots of other evidence-based advocacy projects that are going on in the background and link nicely to some of the stuff we're talking about later, but this was really our kind of first big piece. So as I said, it was to look into the quality of life of acute leukemia, and really some of the things we were trying to do was to highlight some of the unmet needs where work needs to be done to improve some of these things, but also look at some of this stuff from a global perspective that's really not been done before. So some of you might have seen the outputs we've already put out, kind of from the early phases of the outputs of the project, sort of early posters. But I'm delighted to announce for anyone who doesn't know that we've got a journal article coming, which has been the thing that's been holding up our publication of some of this. And because it's now been accepted for that publication, we're able to share some of this stuff today. So all of the stuff I'm going to be talking about, most of it is new stuff that informs a lot of that publication. So it's exciting for us. Next slide, please. So what were we trying to do with some of this? Understand the quality of life of acute leukemia. I mean, that's a fairly obvious statement, but what do we mean by some of that? So firstly, we were trying to identify the factors that were different between the different forms of acute leukemia. We were trying to examine if differences in the quality of life and symptom burden of acute leukemia were observed according to different disease stage. So were people in treatment, were people in remission? Looking at how demographics might vary. Country was a really big one for us, but so was age and gender. And then particularly as a patient organisation, a lot of the work we do is around the experience of patients. So things like the information provision, things like social isolation, and try and understand whether those things that we hear on a day-to-day basis from a patient experience perspective impact on quality of life in a validated way that actually measures overall quality of life. So some of it was, I don't want to spoil what's coming next, so I won't go too much into it. So next slide, please, Samantha. So how did we design the survey? It was an incredibly long and detailed survey, I'll say that from the outset. And to us, it really put pay to some of the questions people were asking about the burden of questionnaires. My perspective has always been if you ask relevant questions, they're quite easy to fill in. If you ask lots of long and irrelevant questions, it's much more difficult. So we structured the questionnaire to cover four main things. The first one was to map the demographics of people because it was a self-reported survey. We didn't have access to clinical records or anything like that. People were confirming the acute leukemia diagnosis themselves and also giving us some of those demographics like age and gender that we needed to do those breakdowns. The second part of the survey was HM-Pro. So HM-Pro is a validated quality of life tool for hematological malignancies. It was developed by the European Hematology Association's Scientific Working Group on Quality of Life and Symptoms. And it was relatively novel when we started using the project back in 2018-19. And the reason we decided to use HM-Pro was because it was developed with the patient community and we felt it most accurately reflected the key quality of life issues that we were seeing in acute leukemia. There were many more other tools that have been around and have been around for a long period of time and were more widespread kind of usage, but we didn't feel that they actually reflected the key issues that we were hearing from patients and came up in our original focus groups and testing as to what we should be including in the survey. The third part of the question was 6 key questions. So those were what we used to design our hypotheses, and they were to basically broadly map areas and see whether those impacted on quality of life. And then part 4 was a more traditional patient experience survey. And that was to basically measure patient experience in different parts of people's acute leukemia journey, and then see whether those impacted overall quality of life. So next slide, please. So a bit more, can we go back on to the questions? Okay, we jump forward to. Okay, so the first thing we did with setting some of this out was a literature search. So obviously we looked around for key search terms in acute leukemia. quality of life. We were limited in this testing phase to the English language. We weren't later, but we were for this period. And when we looked at things that were published in the last 5 years. The fact that only 10 of the 340 publications were considered to be particularly relevant shows you back in 2017-18 how little focus there was in quality of life in acute leukemia, which has changed quite a bit over the periods of time. And we use some of that to inform our further work going forward. Next slide, please. There we go. This is the slide I thought I was getting. So survey questions, just to give a bit more information behind of the kind of things we were asking questions. So from question sort of 19 onwards, all the way down to question 99, was the bit I was explaining around key patient experience questions. So we mapped a lot of the key topics you'd expect to see in acute leukemia, from more emotional topics like depression and anxiety to financial aspects. But also, I think the kind of thing that's not really been done before was looking at the provision of information and education, and whether things like that from a patient experience perspective affected quality of life. Next slide, please. So as I said, we decided to use HM Pro, which is a validated PRO tool. And we did that. We used that tool to get our quality of life score. So effectively, from our perspectives, we weren't necessarily interested in people's HM Pro scores. What we were doing is we were looking at the rest of the questionnaire and seeing if those things affected people's HM Pro score. So we were basically using the HM Pro score as a benchmark. Our key hypothesis questions, effectively, this is the 6 key questions, were buckets that covered on a scale from 0 to 10. They basically mapped to the other 80 questions from 19 onwards that were much more detailed into different areas of patient experience. And they basically mapped those buckets. So there were questions like the information from healthcare professionals, whether information was provided and how they would rate that on a 0 to 10 scale, and whether that affected overall quality of life. The next slide, please. This is the slide where you can't ask any questions because I'm not a statistician, but we worked with statistical teams to look at correlations to determine the direction and strength of the relationships between the measures. And then also we looked at differences between the groups. So the power of the survey that we ran with the number of respondents we had, pretty much every single thing we did was statistically significant when we looked at p-values, and p-values basically didn't tell us very much for any of the stuff because the sample size was so big. So really it was about relationships and differences between groups that were the key things for us. So how did we do it? We did it online. That in itself is potentially a limiting factor, but I think it was the only way it was feasible for us really to do it. And then we also tried to make sure that we were able to do this properly globally, not just English only. So we translated it into 9 different languages. And we actually worked when we were doing this with the HM Pro team to ensure that the HM Pro was validated in all of those languages, some of which weren't. So we actually, as part of this, helped them to validate and develop those tools in some languages that it didn't currently exist in at that time. We then recruited patients via the Alan membership. So we had respondents from 42 different countries around the world. But again, the source of those was from promotion via the patient organization. So again, that's a potential limitation in some of what we were doing. Next slide, please. So we had 522 respondents globally, which in the space of acute leukemia is an absolutely huge survey. It's by far the biggest thing that's ever happened. It was perhaps lower than we'd have liked in certain areas. And part of that was to do with our methodology of distribution. So we had a high number of respondents from Europe, far more than from other regions. So a lot of the breakdowns we're able to do from a European perspective are much more detailed. And we were able to look at that in a lot more detail, whereas some of the other regions are much less granular. We looked at some of the different demographics of some of these things, and the numbers are not necessarily particularly relevant here, but just useful to know for context, because we'll get into some of those breakdowns later. So next slide, please. So this is just to recap on some of the stuff we've already shared, because we haven't really touched too much on this in the publication, because all of the stuff we shared previously with the interim data was confirmed in the final data outputs. So our first initial data that we shared at ASH back in 2019 showed, unsurprisingly, but it's just to confirm our hypotheses, that people who were undergoing treatment would have a reduced quality of life score compared to those who were in remission. And also that, to confirm our key hypothesis, those who report a worse patient experience do in fact report a worse health-related quality of life using the validated tool. So that was quite key to show. We also then looked at, both in this one and the next one, some of the demographic questions, and it came out very clearly from the beginning that those who were female report a worse impact in terms of quality of life. So HM-Pro breaks down into two different parts. The first one is impact, which is things you'd more expect to affect someone's life. And the second one is symptoms, which is more disease related. So the female impact particularly related to part A, which is to do with the impact it was having on people's lives. Next slide, please. So in terms of disease stage, just a deep dive into some of these different bits, and I think we shared more of this detail at EHA 22. So there were significant differences for people who were currently undergoing treatment compared to those who were in remission. We also had a kind of separate group that we called relapsed, and that was basically to separate those out who were currently in the period of relapsing. So they may not have been on treatment, but we wanted to make, because we knew the quality of life impact of that could be quite different, and we wanted to separate that group out. So the different leukemia types showed fairly similar patterns here. The leukemia type wasn't the driver, it was the disease stage that people were currently in, according to the HM-Pro tool. Next slide, please. The next one, and this is all getting very complicated with some of the slides, but it's there for background in case we share it later, which is to show those who reported a worse score, those key questions 13 to 18, so things like information provision, poor information provision was correlated with statistically significant lower HM-Pro scores, i.e. a good patient experience is associated with better quality of life. For some of them, the correlations were weaker for the acute lymphoblastic leukemia group, but that was partly to do with sample sizes just to see whether the correlations were strong or enough to be statistically significant, but we couldn't be sure in this interim data about that case. And there were some differences between the different leukemia groups in terms of the support they received from healthcare professionals, which was one of our questions. And the APL respondents reported significantly more negative responses for support from healthcare professionals than the other acute leukemia types did. Next slide, please. One of the biggest things that really shocked us, and I didn't put together the slides, I'm loving the photo of the shock we had here, was that HM-Pro did not show a significant difference for either of the two different types of quality of life in the tool between the different acute leukemia types. So the driver of quality of life in the acute leukemia space was not whether it was AML, ALL or APL. And again, we looked at these for those different categories. The driver was the things that were happening from either a patient experience perspective, or from a disease state perspective, or from a demographic perspective. So the acute leukemia types, whilst the treatments are very different from one experience, in some cases may be very different, where the experiences relate, they are what's driving the quality of life rather than necessarily the type of acute leukemia in our project. So in terms of looking at relationships between HM-Pro scores and some of those other things to look where HM-Pro scores were worse, those who were younger, those who were female, and those who had a lower income significantly reported lower quality of life in some of these areas. We also saw lower scores in other parts of the region, so we saw a lower negative impact on quality of life in Europe. And as I said before, we saw no significant differences between leukemia types, and again, not based on region, despite diverse different healthcare systems. Next slide, please. Another one, so again, as I said, we looked at those questions 13 to 18 in terms of correlations, And we also actually looked, as I've already said, they were all correlated with HM-Pro, i.e. negative patient experience is worse quality of life. And we also looked at interrelationships between some of those questions. So for example, the management of someone's physical symptoms correlated with the management of emotional impact, and the ability of someone to perform meaningful activities such as get out of bed, wash themselves, etc., correlated with the patient's perceived impact on family and friends. So just to flag on that question 18, our questionnaire was for patients. So we were asking patients what they thought about the impact of them having acute leukemia on the well-being of their carers, family and friends, rather than asking carers of that. The strongest correlation with quality of life in terms of both different parts of HM-Pro was around that ability to perform meaningful activities. And among the questions related to service provision, emotional impact showed the strongest relationship with HM-Pro and quality of life. Next slide, please. So to look into some of the things, some of the other questions, so this is the deep dive into patient experience questions. There's lots of these, like I said, there's about 80, but we've picked out some that really, really were key and showed very strong correlations compared to others. Isolation in the last month was one of the biggest correlations with overall quality of life score, as was the ability to carry out physical activities and the ability to carry out hobbies and enjoyable activities. So those key drivers, we can't necessarily say they were causation, but we can show strong correlations. Next slide, please. So I've banged on at you about lots and lots of data, but what does this necessarily mean in practice? And what does this mean for us from an advocacy perspective? So the first thing is demographics. So the demographics may allow us to either tailor support or to provide further support to some of the key demographics where we're seeing a worse quality of life. So younger patients, those who are female, those who have lower income, not necessarily does that need to be tailored by region, other than obviously language translations. The regions were not necessarily that key driver. The second, in terms of disease impact and support needs, because of the factors related to healthcare professionals, that showed to be a key area around what healthcare professionals were doing to support patients. So things like how they could support them to carry out meaningful activities, and how they could support carers and family and friends would be another one, and also potentially linking to the support provided from patient organisations. Next slide, please. So I think this is my last one, which sort of touches on what I've just been saying there. So healthcare professionals making sure to direct resources to where they're needed most, so potentially signposting patients to patient organisations, support groups, but also providing techniques directly to patients to deal with isolation, which is one of the biggest ones we flagged, and also financial help and advice. Many patient organisations already do this, but lots of other research shows that the provision of this is incredibly low compared to the provision of wider, for example, information about leukemia types. The information around financial and the help and advice is much lower. And we would particularly be mindful, recommend that healthcare professionals are mindful of social functioning and worries about family and friends, which was a key thing that came up, and isolation. Obviously, as we've talked to patient organisations for many times, it's not just about the patient. The ripple effect beyond that is much broader, and patients' concerns about their family and friends was actually a big driver of some of the quality of life. So thank you very much for listening. Hope you found that useful, and happy to answer any questions except for about the statistical stuff. You'll have to send those in the email afterwards. Jump in if you've got any questions you want to ask, or raise your hand. I can see the screen. Any questions? Dan?
Okay, this is Dan Gelvan. I'm from Plico Therapeutics, a small startup company in the field. It's more reflection, but the reflection also includes really a request for response. But we're a small startup company, as I mentioned. We're developing a treatment. I really concur with everything said about quality of life should be considered as you go along the process, and not as a kind of as an afterthought, or not at all. And given taking both the first talk and the second, it seems that there are many ways to do quality of life, and some of them are more effective for blood cancers than others. And I think this is a very strong point for collaboration between patient advocacy groups like Alan and industry, where we would benefit from your guidance, saying, instead of us picking an off-the-shelf questionnaire, that we could work together on getting the best possible and most relevant questionnaire out to the patients while we are doing clinical trials. The second thought is that I heard something that for me is a bit scary. And that is the proposal that the FDA should include quality of life in its requirements. Because the small companies, I'm not talking about the large ones that can afford anything. Small companies basically struggle to put just one compound through the regulatory process. If once quality of life or any other requirement becomes mandatory, it can substantially increase the cost and effort that's required of the company to go through the regulatory stage. And that could mean that some of the stronger small companies would be able to do it, but some will fall by the wayside, and there'll be many fewer attempts of bringing new and innovative treatments to the market. So that should be a balance. And well, these are my reflections. I'd love to hear your response to them.
Yeah, definitely. Well, thank you for the question. I mean, the first one in relation to patient organisations and industry working together on patient-reported outcome measures, absolutely. So it's certainly something we've seen as Alan in the last 5 years with the development of many of the new treatments that Abhishek was flagging, which is companies coming to organisations like Alan, and this is happening everywhere, not just in acute leukemia, but companies coming to organisations and saying, what do you think we should be doing from a patient-reported outcome perspective? What tools should we be selecting? Which most accurately map to reflections of patient experience? When should we be doing these tools? Are there innovative ways that we can be collecting that data? So we've certainly seen a lot of change over the last 5 years, and in a positive way. I don't think it's necessarily all being done perfectly so far. I can see lots of other colleagues on the call who I talk to regularly who have many issues, as do I, with how some of that's done. And certainly we're seeing the voice of the patient in clinical development massively increasing, but we're nowhere near where we would like to be currently. But yeah, I absolutely encourage any company who's interested in doing so to reach out to patient organisations and seek input on the selection of PROs, but also more generally on clinical trial design. And to genuinely do so at an early stage when it's possible for people to listen to those things. There's not much point doing it late on when we're just sense checking a design that's already been finalised. So that's the first one. In relation to your second one around FDA requirements about quality of life, I mean, I think that's quite a philosophical question. Are you happy to decrease the number of treatments that are developed at the risk of having higher standards for the development? Or alternatively, are we happy to use drugs in patients where we don't know the impact it will have on someone's quality of life? Big questions. I mean, certainly from a UK perspective, so I'm based in the UK with Leukemia Care, when we're going through things like the NICE process and looking at the reimbursement of those treatments within the NHS, we look at the quality of life and at the survival to come up with QALYs and to come up with that balance between what impacts it has on people's quality of life beyond just survival. And certainly a lot of the work we've done as Alan is showing that the patient community is very keen on knowing what quality of life impacts of new drugs are, even in an area like acute leukemia where survival prognosis is poor. When you look at things like that in say a CML space, I can see obviously Jan asked a question earlier, and Jan's been one of the advocates pioneering a lot of this work in the CML space. to try and bring a drug to market in CML without quality of life, you might as well not bring the drug to market. So I think there's a big topic of debate there. But I can see Darren, you've also got your hand raised. I think that has to be
Can I just make a quick comment back to you? I'm not advocating bringing poor drugs to the market in terms of quality of life, but making this voluntary and then having the pressure from the community, the medical community. Okay, so show me the quality of life data. A voluntary approach would easily be followed by the companies if it's requested or asked for by the physicians when they evaluate and when they wonder whether they should try a new drug. So I'm talking about good drugs. I'm just talking about the question whether it's a formal requirement or something in the culture.
Yeah. So just the last thing, and then let Darren have a question, is just to say, again, we're not debating whether the drugs are good or not, but the standards by which we hold them to ensure that they are good drugs. So Darren, do you want to ask your question?
Exactly. I just want to say congratulations on your publication in 23. I think it's a really holistic, good overview of the quality of life and PROs. A couple of questions from my side. I mean, I'm fully agree with Dan in terms of like collaborating with industry, but also bringing in regulators, payers, and HTAs, because if we can get the right quality of life questionnaires, specifically for acute leukemias, that would make a lot of sense, because currently we're using QLQ-C30 and EQ5D. And those are generally very cancer specific, sort of general cancer. They're not specific to what happens in leukemias. And if you're thinking it from a CAR-T perspective, patients are generally getting one treatment and then probably getting a really long duration of response where they're not getting any other treatments. And to follow up those patients becomes quite a challenge, even with the current questionnaires. So have you thought about, from a regulator perspective and from an HTA perspective, in the collaboration and getting a quality of life questionnaire specifically for acute leukemias? And then the second thing from my side, just thinking about, and I know we've discussed this before, I mean, this is the biggest sample I've seen. I mean, we struggle even in clinical trials to get like a 50 to 60% completion rate for patients to complete these quality of life questionnaires. You've got about 100 questionnaire. The others are a lot lighter than this and they're still struggling. Any thoughts on how we can improve patients' commitment to complete these questionnaires? Because I'm a big believer of quality of life coming through in terms of the assessments. If you think of Germany with the GBA, I mean, if you don't have a randomized controlled study and you've got a single arm study, they are looking at patient-reported outcomes as part of your assessment. So working together to make sure we can get the right assessment for patients to get the right drugs to market would be really helpful. Any thoughts on that?
Yeah, so I'll take the last bit of your question around the burden of questionnaires first. And actually, I think a lot of it links to what you're saying at the beginning. So one of the biggest burdens we hear from people filling in questionnaires is the irrelevance of questions. So tools like QLQ-C30 from EORTC are by very definition general for cancer and not necessarily specific to hematology. So in some areas like in CML, we've obviously seen the development of CML specific extensions to help make sure you are asking those specific questions. But the challenge is we see with the general bit of the QLQ-C30 is that it was developed in the 1980s. At its core, it wasn't developed with patients, and many of the questions it's asking aren't relevant to the context, because by definition, in general, for all forms of cancer. And what that means is, and I don't just mean them, there are many others, but they're some of the most widespread. But what that generally means is when people are filling in some of these questionnaires, they're filling in questions that aren't relevant to their situation. And so when you say, will you fill in the same questionnaire every 3 months or every month in some cases, you're writing a response to a question that was the same as it was the last time, because it's not relevant, because it couldn't possibly have changed. So how do you feel about going about your everyday activities? Well, I don't know. I still can't get out of bed and it hasn't changed since the last month, so I'm not going out. How do you feel walking about? Well, I don't know. I'm in a wheelchair. It can vary very much dependent on that context and that situation. So one of the things we make sure to do very carefully with our questionnaires is to make sure those questions do map very concretely to the situation that people are in. And there are always options, so you filter out irrelevant questions. And that was actually the reason we selected HM Pro, because it was felt to be we looked at lots of different questionnaires and decided to partner with the EHA team on doing this, even though the tool was very early and hadn't been used very much, because we felt it was the most relevant tool that existed in hematology. I was kind of chuckling when you asked the question because our next speaker, I think, is Ananda. I think she's going to be talking after the break about evidence-based advocacy. But one of the things Ananda is doing in her kind of capacities at Advocates Research is I actually had a call with her earlier today with Erin Yan and others around the mapping and usage of quality of life tools in the cancer space. So I don't know if you want to comment on it, Ananda, but we can, which is the work group of European Cancer Advocacy Networks, so effectively the networks like Alan for Europe, and also HEMCAB, which is the hematology communities group that come together, are working on a project at the moment called EuroAct, where they map the use of patient-reported outcome measures in cancer, whether they're being used for cancer general ones, whether they're using disease-specific ones, and basically to encourage the wider use of PROs, but also to track that data. And the thing that made me chuckle was actually the HM Pro tool. I asked a question to her earlier this morning to basically say, how are we going to map things that work across various different across hematology rather than just disease specific, because they might fall into either of those categories. So that was that. Before I hand over to Ananda to make a comment, one just thing about CAR T therapy was to say, actually, in some cases, these PROs might be treatment related rather than disease related. So in the space of CAR T, do we need an ALL PRO, or do we need a CAR T PRO, which is also used in DLBCL, myeloma, AML, all of the places where we're seeing the CAR T therapies being developed? A broad question for us for the future. We've always thought about disease specific. What we actually mean probably is context specific. So thanks for a really good question. I don't know whether Ananda, you want to very quickly comment on the EuroAct stuff.
I have a slide on EuroAct, so maybe I'll
Save
do
it
it
for
for
later
the talk.
Okay, perfect.
If there's a minute or two, I'd like to make a comment on the question about mandating QOL inclusion in regulatory approvals. So I think it goes both ways. There are, we've had drugs that have sort of not survived the regulatory process because they did not meet certain objective endpoints, but they could have very well, been, and we know from experience that they actually help patients. There are, I can think of one drug in the myeloproliferative neoplasm space where it improved hemoglobin and, improved sort of patients feeling better, but simply was not approved because it didn't meet the sort of the objective endpoint that was mandated. So it goes both ways. It's a lot of investment to use PROs and incorporate and mandate them in approval process, but they can also sort of go both ways and help the companies sort of get drugs out that that may be beneficial. I don't think the FDA is mandating inclusion of PROs, at least at this point, although they are strongly recommending it when trials go to their sort of desk for approval. It comes back often with comments that please consider including this, and it's good to see that. They're not mandating it for now, but I think it's important for the industry to also consider this, because I think there is definitely a strong case for return on investment rather than just something that we are putting on your plate and making you invest for no returns. So that's just, I just like to make that comment. Thank you.
Thank you for the comment.
Okay, so if there are no other questions, so we are a bit behind time. So maybe if everyone agrees, we can just go for a 5-10 minute break max instead of 15 minutes. So it's now past the hour. So if we go back, let's say in 10 minutes to kick off with Ananda's presentation. And coffee time.
See you all in a few minutes.
You can go, sorry.
Yeah, so thanks a lot, Alan, for inviting me to give this talk, and thank you, Zach, for that kind introduction. Next slide. Next slide, please. So I wanted to kick off, and probably this might sound very familiar to many of you, but I wanted to kick off my talk by talking about the different levels of advocacy and how it operates, and to really address the fact that they are very different, and they don't have to coincide all at the same time, which doesn't mean that they're not equally important. Some of us in the patient community work with specifically with patient support, providing information, holding hands of patients, having info days, and really guiding patients through the health system, individual patients. Then there's a different level, which is around shaping policy and regulatory processes. And then there's another one, which is around impacting and shaping research. And very often, I think all of these get confused. And when we speak about advocacy, sometimes we have an image in mind of, a Superman organization or advocate that does all of these at once. But I think it's particularly important also when speaking about evidence that we distinguish them and we keep in mind that they don't happen at the same, or don't have to happen at the same time. Next slide. And so patient advocacy as well operates in a space that is quite crowded, and where everyone has interests, and many of these stakeholders in the space take decisions that affect the lives of patients. And that's why we need, as advocates, we need to find a very wise way to deal with that, to interact, to engage with all of these, but also to inform the decision making processes that happen. And so you can see that obviously patients and individual patients and carers have a very personal objective and interest, which is living a good life and living a good life as long as possible. And patient organizations, as we saw previously, they have the duty and the objective of serving patients in one or another way, or these three levels that I explained before. And we have the interests of media, and that, is about bringing medical news to a wider public. You have interests of academic researchers, of physicians, which is more around the best clinical outcomes. And very often they go hand in hand with quality of life, but that is not the main interest represented by physicians. It's more about the clinical outcomes. And that's why very often it's important to combine them with the priorities and the interests that patients have. Industry, amongst others, have commercial interests. Regulators are focused on safety and efficacy. Their objective is to approve drugs that are safe and efficacious. And then around payers, there's an interest that is more of a societal perspective around the sustainability of healthcare systems. And next slide. And so we have to be sure that we keep in mind that these interests exist, and that not everyone has the same interest that we have, which is not really a problem, but you have to keep it in mind. And so over the past 20 years of patient advocacy, the sense is that we've learned a lot throughout that process, and we've kind of understood that we cannot inform decision making by bringing to the table anecdotes only. And it is true that anecdotes sometimes help to maybe give a face to the evidence that you bring to the table, but it is not enough to just try to inform decision-making processes with anecdotes. Next slide. And that's why many of us are part of a kind of a movement that is called evidence-based advocacy. And evidence-based advocacy has, I think, one main purpose, which is to increase the impact that we can have on decisions that affect the lives of the patients that we serve. And so you become more effective and more efficient at doing that. And so increasingly, I think it is about advocating in a in a targeted way, in an evidence-based way, in a well-educated and professional manner, and also ensuring that you measure the impact that you have with the work that you do and the input that you provide into the whole system, so to say. And that is absolutely crucial. And it's something that I think we're starting to do more and more. You see it with all the evidence, and I'll be showing a couple of examples later on. But it is it is quite a new movement. Next slide. And so when brainstorming about what from a more practical point of view, because I knew that Zach was going to present around the quality of life survey that Alan has developed, and that we were going to have a presentation from a clinician around their vision on quality of life. I think I felt it was important to maybe speak about how, what steps potentially the patient community can take, and what those simple steps are that you need to take into account when putting into practice evidence-based advocacy. And so I think the first one is really, and it's something that also Zach mentioned, is around the hypothesis and the challenges or the barriers or gaps that move you to actually initiate that process of generating evidence. Because I think as such, evidence generation is not the objective. You want to change something. And so to truly identify what that is, what that barrier is, what that situation is that you want to change. And then the second step would be to identify who is responsible for taking a decision that can change whatever you want to change. And I think that's also something that we haven't been very, very good at the past. Well, I mean, some are very good, but the majority of us have been, targeting stakeholders that weren't responsible for taking certain decisions, generating evidence that was totally irrelevant for those that make decisions, etc., etc. And I think it's super important to keep that in mind before you start working on whatever evidence you want to generate. And then the third step would be to really identify the preferred or the ideal type of evidence that will inform that decision-making process. And before doing so, to check whether anyone has already generated that evidence, because very often we start doing something that has already been done. And by doing some desk research, you might, invest less resources and have exactly the same impact. So I think it's not about, as I said before, to generate evidence for the sake of generating evidence, but really because there is a need. And then when you see that there is truly a need for, or a gap in needed evidence, you choose a methodology for carrying that research out. And after that, you choose the right package to, presenting your evidence. And that might be, a publication, it might not be a publication. And I think that is another another big mistake that we often make, is to keep to have in mind that final package that you you want to present to the world, you want to present to your sponsors or to your community, that glossy report, when maybe that is not the right package for what you want to achieve. And so really spending some time on that, I think makes absolute sense, so that you invest your resources in a wise way. And then the last would be to really choose the right action, the right way of approaching your advocacy action. And I think one of the important parts as well is to choose your partners in a very wise way. And you could do that by disease area. So if you generate evidence, or you decide that generating evidence is the right step, then you know, is the evidence that you're generating disease specific, or is it cross disease? Because if it's not disease specific, you might as well join forces with another patient organization or a group of patient organizations to make that evidence stronger, and to even make your action, your advocacy action stronger. It might be by target group. So for what are you going to use that evidence? Are you going to use it to decide on what your internal priorities as an organization are? To say, okay, we need to reshape our strategic objectives as a patient organization so we can help patients. And we need to know what our community, what the patient community thinks, what are the priorities of the community? Or do you want to influence an external stakeholder, the regulator, for instance, or HTA bodies, policymakers, researchers, or industry? Do you want to input into the drug development process? All of this, I think, has an impact on who you collaborate, on how you shape your research, and what methodology you choose in the end. And then obviously there's also the question around the geographical scope. So are you generating evidence to change something at a global level, or to make a point at a global level? Is it something that affects everyone, or is it a European issue? If you speak around access, for instance, is it a national challenge that you want to tackle? Do you want to compare maybe national issues across European countries, or is it maybe a local thing at a hospital level? All of that is something that needs to be taken into account. And I think running a survey or publishing, I said this before, but I think it's super important to keep in mind that it's not the aim, it's not the final goal. It's just one of many vehicles that exist to achieve a goal. And another, I think, very important thing to keep in mind, I don't know what the audience is here in the summit, whether you have a huge budget or a small budget, but certainly when thinking about a survey or when generating evidence, I think we have to move away from that very sophisticated idea, you know, very sophisticated patient preference studies. That exists, and that is very helpful for certain evidence that you need to generate for certain purposes, but it doesn't have to be that way. So there is plenty of other ways of generating evidence that are way cheaper and way simpler, where you can have probably exactly the same impact. And I think that is important. And also, I mean, organizations like Ellen play an important role here. So if you, as a national organization, maybe want to generate some evidence, I think it's very important to reach out to your network, to your umbrella organization, and to try and get some advice on what the best approach is, because I think there's very good advice that can be given here via the umbrella organization, also via WeCan. Next slide. And then, of course, you know, when putting evidence-based advocacy into practice, beware of, you know, one of the common mistakes of patient advocacy organizations, which I already referred to before, which is not really being targeted in your efforts, and investing scarce resources and energy by advocating either at the wrong level or targeting the wrong stakeholder. And here you can see it's really about barking up the right tree, because all of your efforts can mean nothing or can have zero impact if you don't target at the right level or the right stakeholder. And so it's really, really important that you analyze that beforehand and look for help. I mean, there's plenty of people that have done this before and that can help you and guide you on this. And so you would have the different levels, like the EU level or the national level. Just as an example, if you want to advocate for access issues, well, you would not go and advocate at a European level. You would go to European Commission, for instance. And I'm talking from a very European perspective, because that's the area I know best. I'm aware that this is a global network, but there's plenty of other examples where you could do advocacy at a global level when it comes to, for instance, quality of life, like you're tackling in this call. That's something that probably patients share across the globe, and where it's also worth analyzing the differences between regions when it comes to quality of life, and so on and so forth. I don't want to go into detail of this. I mean, you're going to get the slides anyhow, so you can have a look at this. But I think it's really important for you to keep that in mind when generating evidence. So here you see on this slide, you see, so once you decide, that evidence generation or generating evidence is the right step to take to achieve your goal, your purpose, there are plenty of possibilities. And you can see on this slide that a lot of work has been happening already in the patient community. And so, for instance, with regards to disease mapping around the patient experience, quality of life, burden of disease, unmet needs around adherence, around patient preferences, and then inequality mapping as well. And you can also see some very interesting disease-specific examples from the cancer patient community. For instance, the INCA research on unmet needs, the Europa OMO Europrom survey on quality of life, which came out lately and is quite impressive. The survey on from the Lymphoma Coalition on global patient experience, MP's Access Atlas on the challenges and barriers around access, the CML Advocates Network treatment-free remission and adherence surveys, and of course the Allen Quality of Life survey, and probably, which is not here because I guess it's ongoing, the patient preference study that you're working on. And so you see that a lot is happening on a disease-specific level. Next slide. But as stated before, sometimes you might be more efficient or more effective by joining forces with other communities that, face the same challenges that you do in the area where you want to generate evidence. And so there's a huge community behind the acute leukemia community, and there's many organizations that are trying to advocate in the same direction. And so it's important to join forces so we can avoid duplication, and also especially important to learn from each other's mistakes, because I think some of us have gone through very painful experiences when generating evidence, publishing, and so forth. And I think it's really important to learn from those mistakes. And so this slide is here because one example is WeCan, where all the European cancer umbrella organizations come together to work for common themes and also come together to collaborate on research. Next slide. That's for cancer, where Alan, of course, is part of, but there's also, powerful alliances that go beyond cancer. And in this case, I wanted to use the example of collaborations between solid tumors, malignant hematology, and non-malignant hematology, where you would think, what the hell does, solid tumors have to do with non-malignant hematology diseases? But they have indeed come together to generate data on a common, challenges. And here you see all the list of the organizations that are involved in this, and Alan is part of that. Next slide. And the project I'm referring to is the one that Zach mentioned before, EURACT, and it's in I think a very good example of how a joint effort, a big joint effort, looks like. So what the EURACT is trying to do is to map clinical trials across Europe over the past 5 years. So to see where in Europe those clinical trials happen or have been happening over the past 5 years in each of the cancers. And so this was something that was done by Myeloma Patients Europe, and we're now replicating, because when we generated the evidence alone as a myeloma community, we suddenly realized that it was pretty much worthless, well, worthless not, but it was not so powerful to know, okay, in this country, in these 10 countries over the last 20 years, there's been 0 clinical trials. Yeah, that's super bad. So what's the consequence? What are you going to do about it? Whereas if we did this together with the entire hematology and cancer community, you would be able to compare whether that is only happening in myeloma, or whether there's other areas, other disease areas where those trials actually do happen. And by comparing and allowing that comparison, you could argue that it's not an infrastructure issue. So clinical trials can actually be run in those countries. And that is a very important, it's our hypothesis, but if that was confirmed, it would be a very powerful tool for us to advocate, because we could go, I take the myeloma example, we could go and say, well, your argument of telling me that the infrastructure in X country in Central Eastern Europe is not good enough to run a trial. That's a lie, because I know that in breast cancer trials are happening, and I know that in leukemias trials are happening. And so you can have a conversation at a totally different level. And then the other big area where we're generating evidence together with all the others is on PRO tools and quality of life measurement tools. So we're looking into those trials that we're mapping, and we're looking at what PRO tools are being used and whether they're appropriate for measuring, quality of life in those disease areas. And so we'll have a pretty good landscape of whether there's a trend in, certain countries not to use the right tools or use them well, or whether there's certain companies or whether there's a difference between academic research and industry research, etc., etc. Next slide. Oh, and I forgot to say that, of course, Alan plays quite an important role in EURACT, and even we have Zach sitting in the steering committee, which is super cool. And of course, the inclusion of PRO data in clinical trials, we know this is not the norm. That's why we're looking into it with EURACT. And And I think even if it captures, I mean, obviously there's a trend, an increasing trend to include this. There's no, we don't want to deny that. But even when, sometimes when quality of life is captured, very often it's not captured with the right tools, either with the right tools or at the right moment in time or often enough. And I think it is so incredibly important to collect evidence about how patients feel with regards to, you know, the burden of the disease, but also the burden of the side effects of the treatment and how this impacts on, you know, daily lives of patients and, you know, the quality of life they experience. And very often terms are wildly thrown into the room, such as, I mean, we see this over and over again when we're looking at published data or looking at, you know, trial results. Terms like manageable or well tolerated. But these terms, you know, cannot be assessed from a clinical point of view. These terms are totally useless if they aren't defined by patients, because ultimately it's them who have to manage and who have to tolerate these day in and day out. And so the impressive work that Alan has been doing, I think will really help you greatly as advocates to advocate better for PRO tools in trials. And yeah, so what does this mean? What does it mean to live with acute leukemia, to survive acute leukemia, or to undergo treatment? What does it mean to live with certain side effects, or what was explained before in the first session, in the first talk around the relief of receiving treatment, because the burden of the disease is so heavy. All of that needs to be captured. And then, of course, not to forget about the consequences for long-term survivors, you know, when it comes to, and that group will increase over time. At the moment, it's a small one, but it will increase. And so what happens with, you know, with their lives if they survive, with their immune systems? Are they, you know, can they live a normal life? What about fertility and issues like that? All of this is important to capture. And so I think also to capture with the development of new treatments and new therapies that that then take into account all of what matters to patients. Next slide. And so when it comes to patient preferences, I didn't want to leave this out, although I know that this is not, you know, isn't being addressed in this summit. I know that you're tackling this issue. And I've seen that the next speaker, unfortunately, my talk is before, so I don't know, but I'm really looking forward to that talk after me. But it's just worth mentioning maybe the importance from an advocacy point of view, and I'll do this super quickly, because I think we know that fears and wishes and preferences, the needs, they vary greatly, and they don't only vary sorry, from one disease to another. Also within one disease, we very often see very different approaches and perceptions, and it's I think a huge effort, and chapeau, I mean, it's a huge effort to run a patient preference study, but it provides the patient community and the advocacy community with unique insights that will really help, I think, when decisions are made. So really to bring that to the table of decision makers so they understand how valuable or not valuable a certain therapy is, for example, or how willing a subgroup of patients with similar characteristics, smaller or bigger subgroup, are willing to take risks for potential benefits. I think it's really, yeah, anyway. So yeah, I'm looking forward to that talk. Next slide. And so to come to my conclusions, I just have 2 points. So one is that the data of the Allen Quality of Life Survey and the upcoming patient preference study will be a powerful instrument for you all to advocate for better care and for an improvement of quality of life of patients, and to better support patients according to their specific needs in your countries. And in order to achieve the highest impact with your efforts, I think following some simple evidence-based advocacy principles is key, to identify the gaps and the challenges that your community face, to define your target group, to define your partners, to develop solid evidence and not only anecdotes, to package it right, to publish the data if needed, and to develop advocacy tools around that. And then lastly, to bark up the right tree. And here, my talk is finished, but I invite you all to reach out to Alan and to ask about the evidence-based advocacy course that WCAN is running. We're always happy to have new people, new faces there. Thanks.
So same as before, if there are any questions for Ananda, please unmute yourself or raise your hand.
Sorry about that cough. I don't know where it came from. It must be the Friday afternoon cough.
I think so. Zach has a question.
I was trying to let others go first because I talked to Ananda about evidence-based advocacy quite a lot. So my question was going to be sort of beyond what we do as patient advocates in evidence-based advocacy. What more could our industry colleagues do to sort of either support this work or to sort of reduce the need for some of this work to happen? Because I know that patient organisations are obviously, the things we'd like to generate evidence about are limitless, and the capacity we have to generate that evidence is relatively limited. So how do we align that better, or how do industry align that better to sort of enable and improve this work?
Well, it's a tricky one, but I think there's nothing more frustrating than generating evidence, packaging it in the right way, presenting it at the table and being ignored. And I think that still happens. And very often it happens from industry side. And then suddenly when the regulator, sends you back to generate more data, or when it doesn't pass through HTA, you give us a call and say, oops. And so I think maybe working together in a very aligned way, understanding what your access strategies are, understanding how you design your trials, and basically what you're trying to achieve is super important. And very often, I at least that's my perception, it is not fully transparent, and so feeding into that process becomes really difficult. But I think if we all align and we're more open, I mean, in the end, for not exactly the same reasons, but we do want the same thing, right? Those medicines to work and to get to the patient. And yeah, so I think some alignment would be good.
Alexei?
Yeah, I don't have a question. I just wanted to add to Ananda's comments and also to maybe address Zach's previous question about the evidence generation and the right type of collaboration with the industry, right? And I think everything that you, Ananda, said rings true to me. Where I do see opportunities to do more work is the development of a so-called integrated evidence plan, right? So each at Novartis, each compound is, when it's developed, gets assigned an integrated evidence generation plan that is comprised of, early clinical trial data, and then as we move on along the development cycle, we talk about the value and access and the health economics and outcomes research. So it is a sort of a map, right? So which says where the data gap exists and what type of activities we can conduct in order to address those gaps, right? And I think that is that kind of a crucial point where the input and the collaboration with the advocacy partners is crucial for the industry, because this is where the decisions are made with regards to what type of data is generated, and also very importantly, how this data is going to be generated. Are we talking about launching a patient preference study? Are we talking about the primary or secondary market research? Are we talking about, doing the literature search, right? And I think, hearing what you're sharing right now, and also adding the value of your previous experience and basically saying, well, this is what we believe is the right way and this is why, right? And also generating this evidence that brings value not only for the industry, but also for the community at large might be an interesting approach, and definitely something that we're working on at Novartis.
Darren, you want to go next?
Yeah, so I don't have a question. I just want to comment. I want to just build on what Alexia has said and also what Nanda's been saying. I think it's important that the patient voice is brought in earlier to discussions. And I know from an industry perspective, we are thinking about that. I think most companies are thinking about that, how to bring the patient voice in earlier. The other side of it is, I'll go back to my previous question, and that's become like a personal project for me, is if you have a look at acute leukemias in terms of the quality of life questionnaires that have been used. We need to be working together to sort of start shaping that regulatory and payer HTA landscape in what's required. And that's not going to happen overnight. So again, it's early engagement. And I think it's from both sides. So Nanda, going back to your point, like where you were talking about what some of the needs of the specific stakeholders are, you see industry as being commercial. I think that's probably some of the old ways of working. I think the new ways, I think everybody wants to work to make a difference for patients. Yes, industry has a commercial objective because we've got shareholders, we've got to generate enough funding for research and so on. But at the same time, I think we've all got the patient at heart. And I think the sooner we can get together to work together on that and early engagement, that would be my ask. Go back to Zach's question. I think if we can work together earlier, before we set up clinical trials, before we start engaging HTAs, bring you guys early into the discussion, and at the same time have that open discussion. I think that's critical.
Yeah, and I think absolutely. And I think that at least from an advocacy point of view, we've been pushing very hard and pushing stakeholders into directions they didn't want to go. And I recognize this as something that I've been doing as well for very, very long now. And I think it's probably a mistake to do it that way. And that it's much easier to try and look for that sweet spot in the middle where you have an overlap of interests and start there and then expanding, rather than, pushing or cracking your head through the stone, like the image we had before. And I think that's a learning process. Sometimes it's very frustrating for us to see that something that is very obvious needs, and when it comes to quality of life, even more, aren't integrated into into decisions that later have an impact on patients. And a very clear example is, clinical trial design, where you say, oh, I told you this, why didn't you listen? But I think that's, increasingly that is changing. I agree with you.
So thanks everyone. Thanks Ananda. Thanks for your questions. So as Ananda mentioned before, so running a patient preference study is like almost being in touch with a monster, and we do have superheroes with us, so David and Chris, and they are going to speak about why is it important to understand patient preferences. So I cannot see them on the video.
I'm here, Samantha.
You're here. Hi, Chris.
Hello. Thank you. I've never been described as a superhero before, and I'm going to add that to my LinkedIn profile immediately.
You can do that.
My name is Chris Schedule. I'm a director at the Office of Health Economics. We're a health economics charity and research organization. We specialize in understanding the value of new medicines and commenting on value frameworks in terms of how can we make sure that value frameworks are capturing what's important to patients and what's important to society. In introducing my colleague, David, I'd like to echo Ananda's point about the importance of surveys as a tool, surveys and preference elicitations as a tool and not an outcome or an objective in themselves. So part of what David will discuss is what is the appropriate context for a preference survey. Equally, when might you not be interested in a preference survey, but a different form of patient evidence. So to briefly introduce David's point, it will really be about the value of preference studies in translating some of the clinical outcomes that Ananda had on one of her slides, turning some of that information about survival and about adverse events into patient value. How do patients value these outcomes beyond simply numeric outcomes in a clinical trial? And how does an understanding of patient value potentially influence how HTA looks at this, and perhaps how industry adapts and tailors their research around what it is that seem to be unmet needs in terms of what patients need from the drug development pipeline. So with that introduction, I'd like to hand this over to David. David is a senior principal economist at OHE. We work closely together, and I'm hugely confident that he's going to give you an excellent introduction to understanding patient preferences.
Thanks, Chris, and hi, everyone. So yeah, my name's David. I specialize in research around measuring and valuing health outcomes, and I've had a particular interest in patient preference studies since about 2013, 2014, when I started a PhD, which related to this topic area. So very happy to be talking to you about this today, and very happy to be involved in the patient preference study with Alan. Could you go forward 2 slides, please, Samantha? Thank you very much. So I want to start by kind of defining what we mean when we talk about patient preference data. And we've heard quite a lot today about patient-reported outcomes. And so I thought a useful way to begin would be to kind of distinguish these 2 types of data. So as you will know, having listened to the other presentations today, patient-reported outcomes summarize the status of a patient's health condition. They are typically focused on constructs such as health-related quality of life, which means the questions typically focus on things like physical functioning and mental health, although that's not exclusively the case. Some are generic and are meant to cover any disease. Some are meant to cover broad disease areas. Others are condition specific, but they all broadly work in the same way. People will complete a validated questionnaire, multiple choice questionnaire, indicating their health condition, and that's the information you get from those types of measures. Patient preference data, on the other hand, provides information about the relative importance of different treatment characteristics, typically when we're talking about patient preferences. So there we could mean both clinical outcomes and the kind of things you might see in patient-reported outcome measures, but we'd also consider things beyond those kind of outcomes and start to think about the way in which treatment is delivered, for example, such as the length of hospital stays or the type of the mode of administration and these kind of factors that we know also matter to patients. And to collect this kind of data, there are a few different ways. Broadly, you can do this qualitatively, so you can interview patients or conduct group-based activities, or you can conduct a stated preference exercise, which gives you some quantitative data, and I'll come back to the methods later. And just a quick note to say that to add a bit more potential for confusion, both of these kind of data can be referred to as patient experience data as well, which can be confusing as well. Next slide, please. So how exactly could you potentially use patient preference data to inform decision making? I've included here a figure from the recommendations from the IMI Prefer project. If you may well be aware of that project, it was a very large multi-year project involving lots of different stakeholders that sought to see how patient preference data could be useful along the medical product lifecycle. And this flowchart kind of summarizes how patient preference data could be useful at different stages. I'm not going to go through all of this in the interest of time, but really the key point here is to say that in theory, patient preference data could be useful all the way through the product lifecycle. So starting from early clinical development. So we've heard today about clinical trial endpoints. These kind of studies could potentially inform trial endpoint selection. They could also be useful for looking at benefit risk trade-offs, which could be useful for regulators. And also, they provide a lot of useful information around the value of treatments, which could be particularly relevant for health technology assessment agencies. So there's lots of potential use for these data. Next slide, please. So I've kind of alluded to earlier a little bit about the kind of methods that you might use to generate patient preference data. I'm going to go into a bit more detail now. I've just included here a very sort of slimline version of a much bigger chart that's included in IMI Prefer recommendations, just to kind of summarize the type of methods that you might use. So broadly, you have qualitative and quantitative methods. For qualitative methods, you're talking about things like individual interviews, group methods like focus groups or online bulletin boards, and things like that. And that gives you very rich insights into what matters to patients, with very few typically people being involved in those research studies. So you don't need large samples of patients in order to do this. The other sort of group of methods are quantitative. So these give you some kind of numerical insight into the trade-offs or priorities of patients. I can't really spend much time talking about the different methods today, but broadly you have indifference methods, which include things like time trade-off, threshold technique. You also have rating and ranking techniques, and this is kind of what they sound like. So different tasks to get people to rate or rank different treatment characteristics according to their priorities and preferences. And you also have discrete choice-based methods, which I'm going to spend more time talking about today in particular, for a couple of reasons, really. So firstly, because there have been a few different studies that have compared the scope for these different methods to be used to generate patient preference data, the appropriateness of using these methods. And typically, quantitative data comes out strongly with decision makers. And in particular, discrete choice experiments have consistently come out as being a very promising method for producing patient preference data. And then the other thing to say is that we are using this method with Alan as well. So I think it's 2 slides, please, Samantha. Oh, just the previous one. Thank you. So just to give you a quote, this was from a piece of work that Myeloma UK conducted in partnership with NICE. So they were looking at the scope for patient preference data to be used in health technology assessment. And they compared a few different methods as part of that piece of research. And in their sort of final outputs, they concluded that discrete choice experiments stand out as being a method that offers a robust approach, and is capable of looking at the trade-offs that patients are willing to make between attributes. And so this is the kind of thing that we see consistently in these kind of larger studies that have compared different methods and their suitability. Hence our focus on DCs. Thanks. So what exactly is a discrete choice experiment? Well, this method came out of marketing initially as a tool to understand people's preferences for the different characteristics of goods and services. And they were first used in health in the 1990s and have been increasingly applied since, particularly in the last 10 years or so. Their use has gone up dramatically. So in a DC, people are asked to make a hypothetical choice between two or more alternatives, and we're talking about patient preferences here. So this typically tends to be hypothetical treatment options. So which of these two or more treatments would you prefer to take given the option? And the alternatives treatments are described using a set of attributes. Those are the characteristics of the treatment. And then the levels of those attributes are varied throughout the task. And I think this is a lot easier to understand with an example. So on the next slide, I've got an example from multiple myeloma, which may be familiar with some of you. So this was a study that was conducted both in the UK and also in Australia. And this is a standard kind of discrete choice experiment setup. So you have two different hypothetical treatments described here, and as well as the option to say that you wouldn't pick either treatment. And the two treatments are defined using a set of attributes. And so they're defined on the leftmost column. So you've got things like average overall survival and average remission period. And what people are asked to do is then asked to look at all of this information, look at these two treatment options, and consider which one of these two, if either of them, they would choose if they were asked to make this, if they were being offered these two treatments in practice. And so the idea is that people will take into account all of the different attributes and weigh up the two options before making their choice. Next slide, please. So that was one choice scenario or choice task that people would see. But what typically happens is people would make their choice and then they would be given several more. And the structure would be the same, but the actual levels would differ. So you would have different levels for the overall survival for treatment A, treatment B, and so on. And so people would then be asked to make a choice of the two new treatments. And then that would be repeated for typically somewhere between 8 and 12 tasks. And it's that process of altering the levels of those attributes, of those treatment characteristics, that gives the researchers a sense of the trade-offs that people are willing to make and the priorities that they have amongst that set of attributes. Next slide, please. So how exactly do you get there? So as Ananda alluded to earlier, these are big studies. There's a lot of work that goes into them, and they take quite a lot of time. And this is kind of a broad overview of the different stages of a typical DCE study. So the first stage, which really is a very large stage, is defining the attributes and levels. So that's actually coming up with the set of treatment characteristics that you know for a fact matter to patients and make sense in this kind of task. And typically a big part of that initial stage is to conduct some qualitative research. So that's another advantage of this method, is that you don't solely rely on quantitative data. Your quantitative element of the study is very much based on qualitative research as well. So once you have your set of treatment characteristics and you've defined them, you would then go through a pretty much a statistical process to come up with those choice tasks. So to decide exactly which combinations are we going to show to people. That's a statistical process basically. So it's about efficiency and experimental design. Once you've done that and you've got the rest of your survey completed, you can then move on to piloting. It's a really important phase to make sure that patients understand the survey and that they interpret things in the way you expect them to, which they might not necessarily. Once you're comfortable with your survey design, you can then move on to the full launch. And then once you've got your data, of course, analyze it, interpret the data, put it together in some sort of output, and start disseminating your findings. Next slide, please. So it's worth noting that patients play an important role throughout a patient preference study, as they should. They play a role in different ways. So they are the subjects of the research, so the subjects of the qualitative research to define the attributes and levels. They are the people completing the survey, of course, as well. But a good preference study will also seek patient input at other stages. And so getting help on the wording of questions, getting help on the interpretation of the results, and involving patients in the dissemination of the results as well. So you have a mixture of patients being involved as the subjects of the research, but typically you'd also have some element of patient involvement as research collaborators as well. Next slide, please. So I've explained that patient preference studies could be useful to decision makers. I've talked briefly to some of the different methods that can be used and focused in on discrete choice experiments in particular. And now you have a rough idea of what they look like and how they're conducted. But I want to spend a little bit of time talking about the useful outputs that you get from a discrete choice experiment, because this is really the main reason why you would opt for this method over other methods, as long as it's feasible. So I'm going to talk to each of these different outputs, so relative importance, preference heterogeneity, trade-offs, and uptake predictions. So next slide, please. So relative importance is very much the simplest output you can get from a discrete choice experiment. It tells you how important each of the different attributes, so each treatment characteristic is relative to the other attributes. So it's pretty easy to interpret. And it also provides you with a good opportunity to compare preferences between predefined subgroups. So for example, on the right-hand side, there's a results chart from the Australian version of the multiple myeloma study. And in Australia, they had not only patients, but they also had carers, doctors, and nurses complete the survey too. So each of the bars represents a different subgroup. And what you can see is that overwhelmingly, overall survival was considered to be the most important attribute, but other attributes were considered important as well, and that varied between the different subgroups. So for example, doctors cared more about overall survival relative to the other subgroups, although there's a relatively small difference. So this is, the simplest output from a DCE that you can get. Next slide, please. I also want to talk a bit more about preference heterogeneity. So on the previous slide, I showed you a comparison of different subgroups, but when you do a preference study, it might not necessarily be the case that you have particular subgroups you want to look at. Actually, you might just be interested in understanding within this entire group of patients, what kind of preferences do we generally see on the whole? How do preferences differ within different groups, not defined in a particular way? So certain modeling techniques allow you to do this. They allow you to identify clusters of individuals within your sample that have similar preferences. And those individuals may have completely different characteristics, but they have very similar preferences. And this is what this kind of technique will allow you to look at. So the example on the right-hand side is stacked bar chart, comes from one of Chris's DCEs, and this was all about priorities for end-of-life care. And appreciate that the text is a bit small, so I'll just kind of summarize the key point here. So when they used this particular analytical method, they found within their sample that there were broadly 4 groups of people with particular types of preference. The first 3 groups in the diagram here did not consider that survival, extending their life when sort of near the end of their life, was particularly important, and actually other factors such as their physical functioning, ability to be with their family, ability to die with dignity, and so on were more important than surviving for longer. But that was in direct contrast with the fourth group, where survival was overwhelmingly the most important thing. And the good thing about this kind of analysis is you can, having done it, have a look and see what kind of people or what kind of characteristics might result in someone being in that group 4, relative to the other groups, which can be quite informative and can allow you to look at how preferences differ in a slightly different way to having sort of predefined subgroups, which is an advantage of this method. Next slide, please. But perhaps probably the most unique thing that you can get out of a discrete choice experiment is the ability to closely look at trade-offs, and economists call these marginal rates of substitution, but it's a bit lengthy, so I've opted for trade-offs. So specifically, we can look at the rate at which respondents might be willing to trade off one attribute for preferred levels of another. And that kind of information could potentially be used within other analyses that support regulatory decisions or reimbursement decisions and so on, particularly the former. So the example I've got here is an example of looking at maximum acceptable risk. So there was a preference study conducted with people that had severe chronic hand eczema. And the results of their DCE told them that those patients on average were willing to accept somewhere between a 3 to 5% risk of permanent vision problems in order to achieve a clearing of 25 to 50% of their eczema. So this kind of gives you some idea of the level of risk that is acceptable to patients. And this is the average high level result. You can also look at this within different subgroups and look at the heterogeneity within the sample for this particular finding as well. And so this is something that's very unique, in particular to discrete choice experiments and similar choice-based methods. Next slide, please. Okay, so the fourth kind of unique output from a DCE is to look at uptake predictions. And bearing in mind that this method came from marketing, you can see kind of where this came from. So you can take your data at the end and see how perhaps your product, if you're a manufacturer, compares to your competitive products. And so you can do this in the health space. You can see to what extent patients might prefer your treatment relative to the standard of care. As long as you can define it using your discrete choice experiment, you can do this kind of analysis. And so an example I found in the literature below, this is for GLP-1 receptors, receptor agonist treatments for type 2 diabetes in Japan. So that was a discrete choice experiment. They did this kind of analysis and they found that one treatment, I believe was the treatment that was made by the study sponsor, was found to dominate. So 78% of the sample would have preferred one treatment over the other. And that's quite powerful insights that can be used and shown to decision makers. Next slide, please. Okay, I'm not sure what happened to the formatting here. Sorry about that. So just to kind of wrap this up and come back to the kind of objective of the session, in what ways could advocates contribute to these kind of studies? Well, so thanks. One thing in particular that I think advocates and patient organizations and so on are particularly uniquely placed to do is to identify key unexplored research questions. So thinking ahead to new treatment options that are coming through and bearing in mind the kind of things that you hear from patient groups, what kind of questions might be interesting to look at where preferences may play a particularly important role. That's one thing that advocates can contribute. Another is communicating the need for patient preference studies, and obviously patient preference studies aren't always going to be needed, but if there is a feeling that there is a research question that should be answered, that's something that advocates can do, if not work to lead this kind of study, although I appreciate that these are large resource intensive pieces of work, so it's not always possible. Advocates are also really well placed to provide insights into the patient perspective, particularly early on in the project. We found sort of speaking to Alan particularly useful in our study early on and throughout. Advocates can contribute to study designs, and get involved with how the study is conducted. They can assist with recruitment, collaborate with other organizations, to Ananda's points in her presentation. And then and again, also relating to what Ananda was saying, it's really important that once you have the data and you have the output, that's not the end of the story. So communicating the results to key decision makers is really important, and advocates can certainly help in doing that. So these are some ways in which advocates could potentially contribute to this kind of research. Okay, that brings me to the end of the presentation. Thank you for listening.
So I guess same as before, if anyone has any questions, just unmute yourself or raise your hand. Zach has a question.
Not to put you on the spot, David, but could you give a bit of background about the project Alan's doing? Just a quick kind of summary. I think people might find it interesting, and some of the stuff you shared about patient preferences, generally what we might expect to learn.
Sure, yeah, so we are sort of midway through a patient preference study on behalf of Alan. So we are, if referring back to my previous slide, we have just pretty much finished defining the attributes and levels for our discrete choice experiment. And so what we've done so far, the main sort of piece of work that we've done so far is to conduct some qualitative research. So what we did was we conducted online bulletin boards. So that's essentially online forums, and we had patients access the boards every day for 4 days. And each day on the board, there were different questions for them to answer. And it was all about their treatment experience, their experience with the disease. And by the end, we focused on what their priorities would be if they were to need treatment again. So that's in this sort of thinking about the relapse refractory kind of setting, because we had some feedback from our academic steering group that looking at that setting would be informative. So looking forward rather than looking backwards would be helpful. So we've taken that information and we've began designing our discrete choice experiment, which will be in English in the UK initially. We're looking to expand that subsequently. So what we're hoping to do with the results in the end, so as I said earlier, these kind of studies could be used to inform various different types of decision making. I think our initial focus has been on health technology assessment. So when we've been thinking about how this study should look and the sort of considerations we should have when we're designing it, we've been keeping in mind what we have heard from health technology assessment agencies. NICE in particular have given some insight into what they would be looking for and how they might use these data. So that's been the focus for the most part, but I think these data can be used beyond that as well. Chris, is there anything you would add to that?
Maybe just to add some context to that idea of how decision makers might use this. From your example of a threshold study, for example, NICE might want to understand, a clinician may say there are serious adverse events associated with a particular product, but it's useful to understand how does the patient view that trade-off? Are they willing, as you showed with eczema, they are willing to accept some risk for health outcomes. And it's important to make sure that the regulators are aligned with what the patients understand as an acceptable trade-off around some of these things.
Ananda, do you want to go next?
Yeah, just a quick comment. I think from the experience we had, so before the Myeloma UK study, when Myeloma Patients Europe ran the pilot with the European Medicines Agency on what methodology was most appropriate. One thing that we found is that people, they could become really upset by getting asked these questions, even though you explained to them what the purpose was and what you were trying to, because they're so difficult and so hard. And so I wonder, how do you make them more digestible? I mean, they're very important questions. You have to ask them, but they're super tough, and some patients get really upset. So I'd just like to hear your thoughts on that.
I think what you're describing is exactly why it's so important to have patients involved at the early phases of designing these studies. Like you say, the method itself is relatively quantitative, and you have relatively few words to describe a concept that can be either very complicated or very, very emotive, some very loaded emotional aspects that we're asking about, trade-offs between survival and awful side effects. So we did encounter some of the issues you're describing during the qualitative research, that simply in asking people to reflect on their experience, their previous experience with the disease, brought up some things that people didn't necessarily like to think about. And so there were some complicated and even emotional exchanges on the online bulletin board. In some ways, I think our experience with that was, in fact, that the online bulletin board was a very good format, because the patients effectively supported each other on the bulletin board. We didn't need to get involved, which is fantastic, because we're economists and not social workers or clinicians. The other patients, we found, were more effective at managing and consoling and sympathizing and sharing the experiences than any one of us, I think, could have been. So I think it does just go back to the importance of making sure that patients are involved in a meaningful way at every phase in these sorts of studies.
Yeah, and just to briefly add to that, I mean, we have a patient involvement group, and we've been running questions by them and getting their input on how they feel about how you ask these questions, and that's been really informative, really helpful. So we'll be continuing to do that. But yeah, on an online survey, there's not much you can do in the moment. The best, I guess, you can do is to just try and prepare and check with a variety of different people before going live that the wording is appropriate and sensitive enough.
The sort of question and comment from me as well, it's maybe even a question back to you, Ananda, but did you find that was different when you talked to the patient community through patient organisations? So the predominant method for recruitment for the ALAN project is likely to be through, obviously, patient organisations, where it's sort of a self-selected group who are more used to filling in surveys in certain parts. So I'm just curious about your experience there, Ananda.
So we encountered some issues by going via the patient organizations. That was probably the moment when we decided that we had to change our strategy, because going through our member groups wasn't working. We weren't, getting any patients, and I don't know whether it had to do with lack of interest or, different priorities. I don't know, but we then decided to actually well, it's a strong word, but to bypass basically the patient organizations and to go directly to individual patients and to create a database basically of individual patients. You then do get support from the members for translating or for understanding certain things, but they weren't the gateway to the patients any longer. Not ideal, but different topic.
Sounds good. Then maybe we can. Yeah. Interesting to take the learnings from that. Okay, thank you. So I think that's the last set of questions, and somehow magically we've managed to just bring it back to finish within time. I'm just going to end by just really saying thank you so much to everyone who's joined us throughout the day. I've certainly learned a lot from all of the other speakers, all things I already thought I knew about, and definitely realised I had much more to learn from some of the different perspectives. So hopefully everyone else has found, I'm seeing lots of nodding heads, hopefully everyone else has found it as useful and as interesting as I have. As I said at the beginning, next time we do a global summit, we're hoping to do it in person. I hope by saying that we don't tempt fate, but we've been trying to do that since 2020. So at the moment, we're putting plans for an in-person summit to take place next year. Date to be announced, placeholder to come out soon, but we'll probably be doing it in Frankfurt to make it really easy for everybody to travel to, and look forward to bringing all of the community together, patients, patient advocates, obviously some of the clinicians, and also some of our industry stakeholders as well. So hopefully that will be possible next year. So if that's the case, looking forward to seeing everyone there. And last thing just to say, so thank you everyone for joining us. Thank you particularly to all of our speakers for all the effort they've put into preparing their slides. And I think the recording and the slides and stuff will be circulated after this. You'll have access to it if you want to go back and kind of revisit any of those things. But last and by no means least, thanks to Samantha. None of this would be possible without Samantha, who's the network manager. She has put the entire thing together single-handedly. So I think really great work from Samantha, and so thank you so much for organising this and running it all. So great work. So give applause for Samantha. So that brings us to a close. Look forward to seeing all of you soon. And as the slide says, happy Friday and let the weekend begin. At least for those of us in Europe, maybe you've got more time left to go in US, etc. Cool. Take care, everyone. Thank you very much. See you all soon.
Thanks.
Bye-bye. Thank you.
Thank you.
Thank you.
Bye.
Bye.
Thanks.
Thank you.
Bye bye. Ciao. Ciao.